Coming up next, it's going to be the Pulse Radio Show, brought to you with the compliments of MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Pleasant good morning to all of you listeners here with us on Q100.7 FM CBC Radio for what is the third episode of Season 2 of the Pulse Radio Show, a production of the Queen Elizabeth Hospital. I'm Shane Seeley, Communications Specialist with the QEH, your host for this morning. And as you know, the Chief Executive Officer, Neil Clark, is here for the ride as well, because we're really disseminating all of the information surrounding the 2025 to 2028 strategy, telling you about the outlook for your hospital, for our hospital going forward over the next few years. You will see a number of advancements, all with the emphasis on improving patient care, of course, and improving staffing, staff morale, and the list continues. We would have had a good discussion last night on the People's Business here on CBC TV8 with host Tishia Hines, we're the CEO, and our Director of Nursing Services, Mr. Henderson Pender, would have shared some more information about what's happening under nursing and in a number of other areas. We spoke a lot about accident and emergency as well, yes. CEO. So it was a wide-ranging discussion. I really hope that you got an opportunity to see it, and I know that the People's Business, it re-airs on Tuesday, so you can look out for that to see what exactly we're speaking about when we were talking about the strategy and when we were talking about advancements at the Queen Elizabeth Hospital. But let's first, here on this morning's show, introduce Mr. Anthony Harris, who is our Director of Medical Services. He's here to talk about his role in the strategy and what his teams, the doctors and the clinical staff, will be doing to ensure that you, our patients, have the best possible care that we can provide. But first, let's do a little recap of last week, where we really got into talking about 2025 to 2028 and what the Queen Elizabeth Hospital will look like as far as service delivery and a number of other areas, new equipment, etc., etc. It's a long list.
Yes, it is indeed. And good morning to everybody. It's great to be back here with Mr. Harris, who's the Director of Medical Services, our lead for all the medical services at the Queen Elizabeth Hospital. Let's just do a quick recap on what we discussed at the last week's show. And I explained that we've been developing the governance framework, which explains how we operate, how we make decisions, and who's accountable for what. And then we developed the balanced scorecard, which identified how well is the hospital performing and enabled us to identify any trends, performance improvements or deterioration, so we can take action against those particular areas. That balanced scorecard looks at 5 different areas. The first area is service delivery. That's the healthcare services delivery, and they're broken down into 5 subsections. Quality, we're providing quality services, effectiveness, caring, responsiveness, and clinically well led. And that's what we're going to be focusing on today, that first area of service delivery. Other areas that we'll speak about in future shows include infrastructure and equipment, include workforce, include financial sustainability, and includes the IT work that's coming along with the health information system. So if we wanted to talk about then healthcare delivery, and we brought our Director of Medical Services along here. And in particular, we want to focus on things such as what's happening with the clinical services, so the clinical service improvements that we're expecting to bring over the next 3 years, how those improvements might impact on waiting times, both A&E waiting times and planned services waiting times, outpatients and theatre waiting times. And an equally important thing then is also about communication, clinical communication, how well the clinicians communicate with each other, interdisciplinary communication between the different consultants and doctors within the hospital, but also how well they communicate with the patients and the patients' families.
That is critical indeed. Mr. Harris, good to have you on.
Good morning, Shane.
When I spoke last night, I forgot, you have a number of titles. Yes, you are a Director of Medical Services. You are a Island Scholar as well from Harrison College. You're also a cardiothoracic surgeon, one of the leading cardiothoracic surgeons in the region, if not in the Western Hemisphere and the world. You lead the charge as far as medical services are concerned at the Queen Elizabeth Hospital, and you've been given some new directions in this 2025 to 2028 strategy. Speak about that direction and where are we going to see our clinical services go to meet the demands of the public.
Right. Well, Shane, as you know, we are. I like to think of it that we are at a interesting crossroads here in Barbados. We are coming from a state where generalists are the order of the day, and we are seeing a lot of subspecialists now developing. We have neurosurgery at the Queen Elizabeth Hospital. We have cardiac surgery. We have colorectal surgery, and it seems that the general surgeon's definition of what they do is getting smaller and smaller. But of course, you always need the generalists. We also have an ophthalmology department that has really paid a lot of attention to developing their subspecialty interests. We are, when you pass the Queen Elizabeth Hospital now on Martindale's Road, you see a very large sign that says we are the Shaw Center for Pediatric Excellence. And that is no mean boast. We do have a number of pediatric subspecialists, and although our pediatric in-house numbers are not necessarily very large, we certainly can offer every specialty that is required in pediatrics. We are seeing the same thing in the rest of surgery. We are seeing the same thing even in gynecology, where we have a number of specialists and stuff, including our maternal fetal specialists, and that means high-risk pregnancy specialists. So we are at that stage where we're evolving around it, and even in the accident and emergency, we're expecting that we will see people there now who would be specialists. And what we do hope is that would all lead to a better service to the public, a more rapid response given the condition of the patient who presents to the accident and emergency. So it is very interesting times for the hospital, and sometimes I regret that I am coming to my retirement end and that I'm missing out on all the good fun, but it has been something that we've been building. What we have with our new CEO is a drive and a freshness that encourages us to pursue that, to get that done, to recognize the use of critical data to get those services delivered. And probably less sexy, but we do know that the population is aging quite rapid, and the CDRC, the UWI Research Center for Medical Matters, has recently pointed out to us that in the next 16 to 20 years we are going to see the number of people over 70, which will include me, that is going to be tripling for what it is now. So we know what's coming down, we know what needs to be delivered, so therefore I think we have to plan carefully and come up with the strategies to ensure that the population gets the medical service that is required of them, of us.
And that medical service, we can have faith that we are definitely moving in the right direction. Remember that you can call us to talk about this strategy or share any of your concerns with us here on the Pulse Radio Show on Q100.7 FM. Those numbers to call, 434-1007 or 434-1070. You can also WhatsApp us at 434-1007. So you can call, you can speak to us about the strategy, you can ask Mr. Clark a question about, he spoke about it last week, his first 6 months. But you're getting a clearer picture of where the Queen Elizabeth Hospital is going in terms of its services, in terms of improvement thereof, in terms of communication. We're trying to do a whole lot more in terms of communicating to the public. Let me say at this juncture also, for our medication delivery service, we've been doing very well, and we've been seeing an increase in the number of people taking up that service. Over the past few days, we've seen some challenges there, but rest assured that we are making those calls to you so that you can get that medication delivered to you. And today, I remember that we had over 105 packages ready for delivery to Barbadians. So this is just a part of what we're doing at the hospital to enhance all of our services. In terms of the service delivery charge, that is a priority in the 2025 to 2028 strategy.
Absolutely. And we're very fortunate. So whilst we're at the moment designing that strategy, identifying those key objectives, and let's be clear, objectives are just the words of what we want to do. The real challenges in the delivery, the implementation plans and the action plans. But before we develop those plans, we've got to make sure that we've got the objectives correct. We're consulting internally with the staff. Have we identified the right objectives? Are we on the right path? And if need be, we can then amend that. And we'll also consult also with the public on the strategy. We're very fortunate that whilst we have the strategy in development to identify the road ahead, we've also got some real life things happening at the moment. And we've been approved additional staffing at the Queen Elizabeth Hospital. 253 new staff have been approved and will be joining the hospital over the next 2 years. The majority of them will be joining it this year. And that's nearly 10% of our workforce. That's a significant increase in workforce, in clinical workforce, that will help deliver the service improvements that we want against the different specialties within the organisation. And in addition to that, we're moments away from getting the release of our capital expenditure funding, which allows us to buy equipment, much needed equipment for the different specialties. And that's going to the tune of $65 million of equipment to be purchased. Wow. That's over 400 new pieces of equipment for the hospital. And maybe if I can bring in Mr. Harris, he can maybe identify some of those key pieces of equipment that are going to help the services improve the way they deliver the care to the patients.
Sure. Of course, the expansion that we have for equipment will probably be along the lines to let us manage our patients more critically, and allowing us to have modern monitoring systems. So you will see a lot more. The wards at the QEH would now beds would have a lot more monitors. We also have some ventilators. One of the things we had calculated some time ago was the need to be able to to treat people who are presenting sicker, who require a higher level of care, and so we will have to expand our critical care beds, if not our ICU beds, and that is going to require us to have more ventilators, more monitors, and will be able to deliver the oxygens and the medical gases to every bed at the hospital. So you will see quite a bit of those. We have already started, as you would have heard, to ensure that we have the latest in CT technology. We're also looking at the ability to have MRI in the hospital itself. So a lot of those imaging and modern technologies that make a hospital able to do better and better work will be coming to the Queen Elizabeth Hospital. So it is a very good time for the hospital to be expanding at this rate, and I look forward to seeing it, even if it's from afar.
I was now going to say you're not going to be watching out from the sidelines. I know, Mr. Harris. Mr. Harris is not going anywhere anytime soon.
Yeah.
We do have a caller on the line. Welcome to the Pulse Radio Show. Good morning. What's your question or comment?
Yeah, I have a comment. I want to speak about the outpatient department.
Go ahead.
Yeah, the outpatient department. I go there to the kidney part. The outpatient that deal with the kidneys.
The artificial kidney unit?
Yes, please.
Okay, got you.
But I find when you go for your appointment, they give everybody a 9 o'clock appointment.
Mm-hmm.
And when you get there, then, and there is so full. Because everybody coming for 9. And sometimes when you get there, you can't get a seat. You got to stay up, and you got to wait till when the person going to the doctor. Because one time you still have chairs on the side where the doctor units are that you're going to the doctor. But you notice they don't got them now for you to sit down. They will call a certain amount of people to go there. When doctor call, they will be nearby. So other patients that come, they will get the seat in the actual outpatient department part.
Oh.
But now everybody just got to sit down and wait till when doctor call your name to go into the doctor. And you can't get a seat because or sometimes you got to go and sit down there where they do the dressing. And then when the dressing people come, you take up their seat. So them ain't got nowhere to sit down either. And they coming from all Green bus stand, down by the Princess Alice bus stand.
You take
Or
a
they
long,
will be
long
calling
trek.
me and they got to walk all up by the hospital.
Wow.
And then when you get there, you got to stand up all that long time. It's terrible when you feel that I am an elderly person. I'm not a young person. And then you have to wait. Me go to an appointment, and sometimes you ain't leaving in there till 4 o'clock.
Mm. Okay, we got Mr. Harris here, who's the Director of Medical Services. And I've heard this complaint a number of times in terms of the appointments. People coming
Yes, please.
for 9 o'clock appointments or whatever the schedule is. What
Yes,
happens there,
please.
Mr. Harris?
I think again it is, if we really analyze it, Shane, the fault is a bit of laziness. I know that we can give patients appointment times. I think this is something that we have been grappling with, ma'am, for many years.
Yes.
How to fix that problem.
Yes.
We understand that it is a particular problem, but I
Yes.
think that people who are coming by bus like yourself
Yes, please.
or coming from rural areas
Yes.
also come there. Even if we were to give an appointment by schedule, they would still come early and stuff like that. We know that because we have experienced that. We have gone through that. So
Yeah, because people
it
that
really
causing
is.
you,
It
but
really.
the people that coming from rural areas, sometimes they have to leave early to catch a bus because
I know.
if they don't leave at a certain time, they won't get a bus.
A bus
It's
at
too
all,
late.
right.
Yes, please.
And those are some of the things. We are acutely aware of that. And
Yes,
we
please.
certainly, I know we don't want to talk about it necessarily at this stage, but we are looking to explore options of expanding the outpatient services
Oh.
and to provide a nice lounge where people can wait in comfort. I think that has to be a goal of the Queen Elizabeth Hospital. And we have to be sensitive to these things. I think it
Yes.
is a very real problem, and we do try our best because you're right. In the early mornings, up to about 1, 2, sometimes even 3 o'clock, the outpatients are still overcrowded,
Yes.
and then after that it's empty.
Yes.
This is a hospital, as you know, that we are celebrating
60 years.
60 years of opening.
Yes.
And so this was all designed at a much slower time. A time when, it was put there. There was the bus stands weren't one far away and one close. Every bus used to go to Fairchild Street, so that worked very well. I think we are at the time though where we have to rethink, our service to the public and ensure that we are serving them properly, and that we understand their reality, which is that if you're traveling by bus and you're coming from rural, you can come early even if you got a 1 o'clock appointment, because other than that you may not get to the clinic.
And Shane, I'd just like to add on to that within the strategy we've got for 25 to 28 is outpatient scheduling, and that will look at how we schedule patients into those outpatient clinics, and there's different methods of doing that, partial scheduling, full scheduling. I do appreciate the fact that a lot of people come early because of the transport. So as Mr. Harris alluded to, that we are looking at creating a social area within the hospital that people can wait before they move towards the outpatient clinics, so we can create more space. Another important piece of work we want to do is to work with the Ministry of Health and Wellness on which of the clinics we can move into the polyclinic. So can we provide what I would call outreach services? So our consultants can work from a different location nearer to the public that they're serving, which would also then additionally create some more space for us within the hospital. And that's something that we will be discussing over the next few months with the polyclinics and some of our specialties as to how can we move some of those services out. And just one more thing that we're also exploring, using technology for some of the outpatient appointments. So telemedicine, appointments done virtually, and they might not fit all the services and they might not work for all the patients, but a number of patients might choose to take up virtual appointments rather than real appointments. So lots to come on outpatient scheduling. We do appreciate your concerns. I have seen myself firsthand the number of people waiting in those corridors for the outpatient appointments, and that's therefore one of the priorities that we must address.
So I really hope that gives you something to chew on, some food for thought, as we seek to improve the services, especially in those outpatient areas across the board. As Mr. Harris says, we need to work on a nice, comfortable lounge where people can come and be a bit more comfortable as they wait for their service to be provided. And a number of other things that the CEO mentioned there that are in stream. We're in those initial talks with the Ministry of Health to have those outreach services hopefully placed in the polyclinic setting. So it make it more, it make it easier for people like you, so that you don't have to take possibly 2 buses. You can go to that polyclinic closest to you. Yes. So we're working on it. But we thank you for raising that concern. It is a concern that others have shared right here on the Pulse Radio Show, and we are working to address it.
One more thing.
Go ahead.
I would like you all to educate the public more about this kidney disease. Because you don't know when you have kidney disease. Because when the first polyclinic referred me to the hospital, and when I got there, I told the lady that, well, I don't got no back pains or nothing. So she told me that back pain don't really have nothing to do with kidney disease.
Yes, you're very right.
She told me that, but I thought you come along here that when your back hurting, probably your kidneys are getting bad and such like. But she told me it isn't that way. And
that's why we have Mr. Harris here as well, to break down, to be a myth buster.
Yes.
Of sorts, because there are there's a lot of incorrect information out there, and we have our specialists come in who can correct it for the general public, and none better than Mr. Harris here. So Mr. Harris, and recently we were speaking about kidney disease because we were the beneficiaries of 2 new dialysis machines. 2 new dialysis machines we received from BIBA, the Barbados International Business Association, worth over $80,000. And as Mr. Harris would have mentioned during that ceremony, during the handover, we're seeing more patients coming into the hospital with kidney disease. So we need to be able to meet that demand, and we really salute corporate Barbados, and especially BIBA in this instance, for their donation through the Ben Arundel trust their charity in memory of him. And I know Mr. Harris would mention a brief bit about Mr. Arundel's contribution to the landscape here in Barbados, but especially to helping us get equipment at the Queen Elizabeth Hospital for the artificial kidney unit. So, Mr. Harris, break down those myths. Final thoughts from you, caller?
Well, I thank you all very much for what you all are doing and what you all are about to do.
Yes, and we appreciate you for calling us.
Thank you.
So y'all have a very good day.
Thank you, ma'am. You too.
Thanks once more.
Thank you. Let me speak very quickly about...
Yeah, well, you're not wrong, but you're not completely right. I think that if you have an infection in your kidneys, yes, it would present with some back pain. If you have an injury to your kidney, like trauma, you would have some back pain. But this is a slow progressing chronic kidney disease that will go on to kidney failure. That would not present with back pain, and that is why it's important to have your routine checks after a certain age with your doctor. He will check your blood, and we will see a rise in the things that the kidneys clear. If you get a buildup of your urea and your creatinine, that is basically the early start to renal failure. And if it is early enough, it can be reversed with good management of your blood pressure and things like that. So it is important to be conscious that it can happen, and get to your doctor early, and you can certainly delay or even reverse some progression of the kidney disease.
We have another caller here on the Pulse Radio Show. Good morning. Welcome, caller. What's your question or comment?
Hi, good morning.
Good morning.
I have a query, and this is in connection with pending gynecology. I find that normally I will get my appointments the same day that they do neonatal.
Right.
And sometimes it could be a bit pressing because they tend to normally give majority everybody the same appointment, which would be other 12 or 1. And okay, it's a process, we understand. And I don't mind waiting, but my thing is, as I say, it becomes a bit pressing. So my thing is, when you go, sometimes the neonatal may not always be over, which may push back your time to see the doctor for gynecology clinic. So my query would be, query for, can it not be arranged to have gynecology on a separate day so it wouldn't clash with the pregnant ladies? Because time setting is one, and I have heard one doctor complain how tired she was, and it couldn't be easy for her having to do neonatal and then have to deal with gynecology. So I could only imagine how she would have felt having to go through a process from early in the morning up until the point where gynecology closes off.
Understood. Mr. Harris, you understand what she's speaking of?
Yes. Well, basically what we have, Shane, is that the obstetrics clinic looking after the pregnant ladies tend to occur in the morning, and then gynecology looking after the women with women's health problems is done in the afternoons. That is true. Now, one of the we know that one of the challenges that the hospital does face is that there perhaps need to be, I heard this expressed by one of my more senior consultants, is that we probably need to consider a mechanism where we can have increased clinics, and therefore not having large numbers of people going to the clinics and that we are now experiencing. The only good part of that, and I'm sure the Prime Minister wouldn't agree that it's a good part, is that the obstetrics, the pregnant women, numbers are falling. In fact, we have seen quite a dramatic fall in those over the years as Barbados' birth rate declines. But I understand what you're talking about, and I do think that it all comes back to the fact that we are going to have to come up with plans and workarounds that allow us to have more clinic times.
Just to add on to that, if I could, just
Sorry
to add on to...
But my thing is too, as the previous caller would have said just now, then you have to wait. Sometimes you don't leave the hospital maybe 4 or 5 o'clock. Then you got to hustle now for the bus, and then you're not only hustling for the bus, you got to now struggle now with these school children, and then those coming from work who have to traverse on the bus as well. Then the traffic, it's be a bit pressing. So my only thing really was like you time frame you go, and then you have to wait that long period of time because of both clinics clashing on the same day. So that was basically my concern.
Yeah, and just to add to what Mr. Harris said, we've mentioned about additional staff coming to help with some of the waiting time challenges and the additional equipment to speed up some of the services provided. One of the things that we're also bringing in is what I call service improvement managers. And the service improvement manager's role is to actually follow that patient pathway and see where patients get stuck and then unbottle that and using the data. So there's many different ways of scheduling outpatients that I've seen, both in the Middle East and back in the UK. There's many different ways of managing this. And I think what we need to do is start collecting information so we can see where those clashes are. We can see how many cancellations are happening per clinic, the activity going through the clinic. The challenge at the moment is getting the data is quite a challenge because it's all manual data. We, Mr. Harris and myself, met with the consultants recently, looking at some of the outpatient data and the outpatient data and waiting times to start those discussions about how can we use data to inform how we practice and inform what we change. So when these service improvement managers come along, and one of them will be dedicated to what I call the planned or the scheduled care pathway, which will include outpatients and theatre scheduling, and their job will be to make the outpatients and theatre scheduling more efficient and reduce the waiting times and to reduce any cancellations. So I am excited that those posts have been approved and those staff will be coming, and that one of them will be tasked exactly to looking at the outpatient scheduling.
Does that answer your question, caller?
Well, yes. It actually put my mind at a slight ease, know that I'm understanding, because as I say, you don't mind waiting, but just to know, get some kind of understanding that you would know, well, you can operate to suit whenever you have the appointment, so you won't get that cranky and impatient. Another thing, which will be my final query, the last time that I would have had my appointment with them, I was querying from my doctor as far as like prescriptions are concerned, because sometimes you get through kind of late and the pharmacy may be closed at the hospital. You may have to go back down now the next day, depending on where you're living. So I was querying from her, like having it written that I could get it filled in the parish where I'm from by my polyclinic. And she did it. But then when I got to the polyclinic the next day to have the prescription filled, they told me I would have to go back to the hospital with it. And that was kind of strange. Because she gave me the guarantee, well, yes, it can be filled at the polyclinic, no problem. She wrote it up, but then when I got there, they told me they can't fill it, I got to go back to the hospital with it. So I don't know. That had me kind of puzzled as well, too.
What happened there, Ms. Harris?
Well, I'm not sure what happened exactly there, but I want to say the hospital, the government service has a two-tier or two different streams for prescriptions. As you would see there, the hospital has a yellow prescription, and the polyclinics
carry a blue one, yeah.
A different color, right? And so that is it. And I think that was done just for budgetary convenience so that we can track things better and stuff. But I just want to add, and Mr. Seeley had mentioned it earlier, that the hospital, well, I guess it was thanks to COVID and trying to keep people out the hospital, have developed their home delivery service for medication.
Indeed.
Which has been widely successful. And so I think it really is something that the public is encouraged to take up more and more, so you don't even have to go anywhere. It will be delivered straight to your house. I think it's a monthly fee of $10.
It's a nominal fee. And when you compare it
hardly
to the
anything
bus fares, it's very attractive. You'll actually save some money. So that I always try to drive people to the medication delivery service. You can go to our website www.qehconnect.com and just find out how you can sign on to that service, and I will definitely share more details as the program continues about how you can sign on to the medication delivery service. And then if you have any further questions, you can always call our patient advice and liaison service, better known as your hospital pal or help desk, at 536-4800. Our medical team on that line will give you any information that you may need as far as the medication delivery service is concerned. And at this hour, they are currently assisting the medication delivery service with those orders as well. So you have options, but it's all about giving you the best option, whichever suits you. For some people, the best option is to come to the hospital and sit down and have a conversation with their friends who they plan to meet in the pharmacy area at a certain time. For others, they like to be at home relaxing, and then hopscotch, they come and deliver it right to your door. And as far as I've heard, that interaction has been very pleasing for everyone who has signed on to this service.
And that's the thing, isn't it? It's patient choice.
Yeah.
Yes.
What works best for the patient.
Indeed. So really, caller, I hope that
yes, it
helps
did
them
give me
put your
some
mind at
clarity.
ease.
Yes, it did give me some clarity, and I thank you for being patient with my question. And I hope you gentlemen have a nice day.
Yes, we appreciate
Thank
your raising your concern, because without these complaints or concerns, we can't improve what we do at the hospital, right, CEO?
Yes, well, we always say if we don't hear it, we might not know about it. So we always welcome any concerns that anybody has. Let us have those. We can investigate those and identify anything we can put in place to make improvements. We want to make those improvements. You need to let us know what the concerns are.
Yes, you're listening to the Pulse Radio Show on Q100.7 FM CBC Radio. We got to thank our sponsors, MedSafe Medical Supplies, for really signing on and making sure that we can bring the information to you. We'll take a quick break and be right back with more on the Pulse Radio Show.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Back with you. It's 11:40, 20 minutes to 12, so we have just under 20 minutes to go here on the Pulse Radio Show to answer your questions and concerns, and also to share more on the 2025 to 2028 strategy for the QEH, just to let you know where your hospital is going, what direction the executive directors, the CEO and team are taking your hospital. It's all about painting a brighter future for the QEH as we celebrate 60 years of serving the public. A lot of activities will be happening, and we are also considering, we're examining putting on something for the public as well, so that they can come in and share their thoughts. More details to come on that. You need to tune in to the Pulse Radio Show to find out how you can be a part of giving your bit to put into our 2025 to 2028 strategy, because we need to hear from you as well, and that's why we are here. Where are we going next, CEO, in terms of rolling out the strategy? Of course, we're focusing on the agenda under the DMS.
So maybe we could ask the DMS to speak to us a little bit about the developments that's going to happen in oncology services, new equipment and new staffing, and then maybe also what's going to happen with ophthalmology and the eye clinic and the roof that's going to be repaired up there for us.
Yes. Well, let's start with oncology. Certainly this is, once again, we are acquiring a very advanced state-of-the-art machine called a linear accelerator, and what this have the ability to do is to deliver radiation to a patient in a very precise and focused way, so that we are able to only radiate the tumor and not the rest of any surrounding organs or even the skin, thereby reducing the complication rate. And what that allows us to do is to be able to get up to the levels of radiation that would offer the patient the best chance of a curative procedure. And as you know, we are seeing everyone knows someone who has cancer and does require some radiation therapy and some very elaborate and expensive drugs. But if we can treat people effectively, although it appears expensive because of the upfront costs, we know that it is cheaper over the long run in taking care of those patients, along with better outcomes. So we are pretty excited to be able to get this linear accelerator installed in the Queen Elizabeth Hospital, and it is just one of the many things we are doing for the increased care of cancer therapy, conditions.
Yeah, before you go on to ophthalmology, because a lot will be happening there to create more theater space, etc. Let's go back to the phone lines. We do have another caller. Welcome, caller, to the Pulse Radio Show. What's your question or comment for us?
Very good morning to you.
Very good morning to you.
I have a problem here with my eyes. I've been attending the clinic for years, and for the past year or two, all I've been getting is repeats of my prescription and not seeing the doctor.
So, caller, before you continue to express your concern, please, if you can, we would really like you to turn down your radio so that we are listening to you, because we are also hearing the echo from your radio. So you just listen to us and we listen to you.
Just hold on.
Okay. So as we hold for the caller in terms of hearing their concern.
It is off.
Okay, thank you. So you can continue with your concern, sharing your concern about your eyes.
Yes. All I've been getting is repeats. I was due for surgery for my... I had surgery for my left eye some years ago. And I was due for surgery, it was last year, April, for the right eye. And every time I go, I get put off. I never had the surgery. And yesterday, I got up seeing well, and all of a sudden, my right eye went blank. So I want to know what's the position. My next appointment is the 2nd of December.
Yeah. Well, one of the things that Mr. Seeley just alluded to was the whole fact that we are part of our strategic plan, right at the top level of priority, is to expand the number of operating theaters that we have. We have a large outpatient clinic in ophthalmology. Well, almost all ophthalmology is outpatients, and the guys are trying their best to deliver care and stuff to a large number of people. Although it may seem individually that there's rationing going on and people keep getting put back, please understand that it is not for any individual or personal reasons, but just trying to manage a large number of patients. The expansion of the number of operating theaters for ophthalmology will allow us to triple, if not quadruple, the throughput that we would have for people waiting like this gentleman, and hopefully this will be a thing of the past. What can he do now at this time? I think, of course, if he's given the appointment for 2nd of December, the first thing he has to do is come and be there on the 2nd of December and get his thing. We do have people are prioritized for their conditions, and if he is now really threatened with blindness, then I'm sure he would get his surgery at the top of the list.
So what must I do now?
Well, sir, interestingly, the ophthalmology department is the one place that you have a walk-in clinic. You can walk in if the eye that you were depending on has given you trouble. You can actually go to the Queen Elizabeth Hospital and present without appointment to the walk-in clinic at the ophthalmology. It really is one of those unsung strategies that the ophthalmology department has put in place, and I think it serves the public very well. If you do have a problem with the eye that came on suddenly and acutely, I think you should go and see see that clinic. I think it is a little concerning that you were in a steady state and then suddenly it deteriorates. I would not make any assumptions, and if I were you, I would turn up and go to the walk-in clinic at the hospital.
That is upstairs the regular. We see the regular.
Yes, sir, it is.
Yes, in the Lions Eye Care Center, on the second floor.
The second floor.
In the Lions Eye Care Center.
That is.
Yes, but
that's where you regularly go.
Yes, just let the nurse know that you are coming to the walk-in clinic, and you would be. You wouldn't be in the regular stream of the ophthalmology appointments.
Yeah, you will be facilitated. And again, if you have any concerns with that or any further questions that you need to ask, again, call the help desk, 536-4800. They will give you directions as well. 536-4800.
Let me get that number, please.
536?
536.
48.
Just a minute. 5, 3, 6, yeah.
48.
4, 8.
00.
0.
Right. And you keep listening to the radio show because it's one of those numbers that I repeat pretty often, so that people get accustomed to hearing it. It has a ring to it, and you can ring it and get all the information that you may need.
All right, thank you.
You're very, very welcome, and thank you
you
for calling the Pulse Radio Show.
You're welcome, sir.
So, funny enough, we were heading to ophthalmology.
We were.
On the second floor. And then we had a caller speaking about some concerns that he had with his eyes. So let's go to the ophthalmology department and the advancements come in there. I must salute the Lions again for another recent donation.
Yes.
Philanthropy has been good to us, and they donated us another piece of equipment and gave a renewed commitment as well to helping us deal with those theatres that we need to open up on the top floor and dealing with the roof.
And the Prime Minister said unequivocally to me that we have to get that roof fixed and we have to get those theatres open, and that's what we're doing as we speak. We're out trying to identify the civil works required to fix the roof to enable us to reopen the theatres, and we've identified the surgical equipment, and we have the funding stream for the surgical equipment to go into those theatres. So as Mr. Harris was saying, that will significantly increase the capacity in ophthalmology for doing the surgical interventions, but at the same time it will free up theatres elsewhere in the hospital for other specialties like orthopaedics to catch up on their waiting lists.
Yes, and of course, but that's not all that the ophthalmology department is planning. The ophthalmology department certainly is in the process of discussing with the Ministry of Health to bring ophthalmology clinics into the polyclinics. And I think that would also clearly the polyclinics are strategically placed across Barbados, and it's almost like you having it in a community catchment area, as it is called. And if that can be worked out and put in place, it would mean a trip to the crowded hospital ophthalmology clinic would be a thing of the past, and that you would only go to the hospital for preparation for procedure and procedure itself. So I think we do have a chance to, in the near future, to see significant improvement in the ophthalmology clinic. Of course, we are in the single operating theatre that we have for ophthalmology right now. Imagine if we are able to expand that to having 3 theatres. You can see suddenly, even without a increased number of ophthalmology consultants having sessions, that you're tripling and even quadrupling the number of cases that we can do in any given time period. So these are all interesting times, and I really have to say that the ophthalmology department has planned their development and stuff very well. They have a number of consultants attached to it in one way or the other, full-time, part-time, and so forth, but they all represent different specialties in ophthalmology, so we would be able to provide a ophthalmology level of service that was a long time in the planning and a long time dreaming about, to ensure that we deliver the service to the public of Barbados. So it really is getting exciting for the Queen Elizabeth Hospital and what it would be able to deliver to the public.
And that will significantly help to reduce those waiting times and cancellations.
Yes.
For any surgical procedures or anything like that. Remember, you can call us. We only have a few more minutes here with you on the Pulse Radio Show, 434-1007 or 434-1070. You can also send in a WhatsApp for those of you who prefer that method. 434-1007 is the number you will use for the WhatsApp. So we're getting additional staff to cover a number of these areas. In terms of the accident and emergency department, and I know that is a big thing for the population. They want to see improved wait times, and you really went into this last night on the people's business as well. With
Yes.
the additional staff, we'll be able to do so much more.
Absolutely.
Of the see and treat. I remember the Director of Nursing Services, Mr. Pinder, saying that with the nursing practitioner, we'll be able to have a situation where we'll have those additional nurses that we have with those specialties doing a lot more see and treats and reduce wait time and even spending time within the accident and emergency department.
Yep, so the nurse practitioner can manage patients on her own in the emergency department within given guidelines. But we have the additional staff coming into the A&E department include 6 more physicians. So what will be a real challenge for the A&E is having sufficient doctors to see the number of patients arriving through the doors. 6 more physicians will significantly improve that. Additional nursing teams are coming in to support the A&E department. The equipment that's coming into the A&E department, the CT scanner and the X-ray machine, will mean the diagnostics can be done much quicker, much closer, without having to move the patients around the hospital. There's a piece of work being done led by our Chief Operating Officer called the Bed Optimisation Plan, where we're going to help work how we can free up the beds to keep the flow moving through the A&E department, and that will include looking at an emergency admissions unit. It will include looking at discharge planning from time of arrival. Every patient should be having an estimated date of discharge so we can see clearly where somebody's up to within their inpatient stay, and ensuring that we have safe and timely discharges from the hospital, and we have options to discharge people too. So that's a piece of work that Christine, our Chief Operating Officer, is leading on, and when we bring her onto the next show, she can give us some more information about that. Because A&E is a complicated process. The bottleneck or the delays will be seen in the A&E department, but that can be resulted because of later delays in diagnostic services, delays in accessing a bed, delays in accessing a medical doctor to get a specialist opinion because they're somewhere else on a ward round, or if it's a surgical doctor, maybe even in theatre. So it's trying to make sure that we've got the systems and the processes which allow everybody to support that patient flow. We've got a piece of work happening at the moment where we're reviewing the escalation of the A&E waits. And when A&E gets busy, we need to, even before it gets busy, we need to have triggers which say it is starting to get busy. And the obvious trigger is how many people are coming through the door each hour. And we know from data what the patterns of attendances are. So if the attendance is double than what it normally is, we're going to be having a problem further down the line. So we need to be escalating much earlier what we can do when we're busy. So we're currently working with the different departments and teams to say, what would those triggers be? What's the right triggers? And then when we hit a certain trigger, the first trigger, what can you do extra? And it might only need an extra hour or two of support at the triage desk or somewhere else to keep that flow moving. So working with the teams to identify themselves what they can do to support, and that's the teams within the A&E department, the teams in the diagnostics department, the teams on the medical wards. What can everybody do to support this bulge of patients coming through the department so we don't have the excess weight? It will take some time while the people discuss and agree how they're going to manage that, because of course I could just write a plan, and writing a plan for them doesn't mean they'll understand it or implement it. And this is why it's really important that we do it properly, that they write the plan with us, so we're all clear on what the challenges are and how we're going to address those.
Indeed. Let's go to the phone lines very quickly for our last caller for the show. Welcome, caller. Good morning. What's your question or comment?
Good morning.
Good morning.
I have a problem that I had an operation at the hospital some years ago.
Right.
And it's developed an infection. Last year I was sent from the polyclinic there, and they did x-rays and told me my leg was infected and I would be put on the waiting list. That was last year around April. They told me around November. This is actually November again, and I haven't heard anything.
And this is the waiting list for
dealing with the infection in my leg.
Oh, okay. Alright, got you. Alright, so this is what I'll ask you to do, caller, because you caught us a bit late. It's 11:59 and we only have 1 more minute, so it'll be a bit too tight of a window to answer your call and your concern. Can you leave your name and number, your contact details with our producer so that we can get back to you and respond as best we can? Also, you can call 536-4800. I've repeated that number quite a few times during the show. And give your details there so that we can respond adequately to your concern and get you that appointment that you need. 536-4800.
Okay, by the time I can leave it with the
producer right here on the line. Yes, he will take your details off air. So thank you very much for sharing your concern with us, and we want to hear more from you. Remember, again, I'll repeat it one more time, CEO. 536-4800. That's the number that you can call anytime you have a concern, a question, query, whatever. We need to hear from you so that we can better serve you. So you can try that number. Also, for those of you interested in signing on to the medication delivery service, that number is 536-4804. 536-4804, and you can call between 9 in the morning and 3 in the afternoon. Yes, to sign up, but to place your order. You'll get the instructions from the person who manages that service, Trudy Griffith. She's doing an amazing job filling those prescriptions and making sure we get the medication to you. Final thoughts, CEO?
We've got an exciting 6 months, 12 months coming ahead of us. Mr. Harris will be staying with us to move us forward
Yes,
along those
he
routes.
will.
I just want to say also a big thank you to all the staff at the Queen Elizabeth Hospital, because it is going to be a challenging 6 months, next 12 months, 6 months as we move forward and start the implementation of the strategy. And the staff have been super supportive, working really hard, and I've been really impressed, and I'm really grateful for their continued support as we move the Queen Elizabeth Hospital forward.
Indeed. Final thoughts?
Yes, I echo the CEO's sentiments. I think that I myself sense enthusiasm in the staff to get things done and to be part and parcel of the whole process. It's going to be a good time to be an employee at the Queen Hospital, and hopefully it would be a good time that for patients coming into the Queen Hospital. Hospitals are always easy attack areas, but we must keep trying. We are not here for praise, but it certainly and as the CEO said earlier, we are not afraid of the criticism because it tells us what we have to tackle next.
Indeed. And remember, you can always get more information right here with us on the Pulse Radio Show every Monday from 11 a.m. to 12 midday. For more information, you can go to our website. I encourage you to go there to see all of what we're doing, and including our podcast, so you can get a second listen to the show. We post the podcast on our website. That's www.qehconnect.com. And yes, and it repeats tonight as well, right here on Q100.7 FM. So stay tuned to your favorite station for a lot more from the Queen Elizabeth Hospital, and we have some exciting things coming visually for you with this show. You'll see it soon, and more details to come on that. I'm Shane Seeley on behalf of my CEO, Neil Clark, and my Director of Medical Services, Mr. Anthony Harris. We want to bid you a good day. Enjoy the rest of your week, and please stay healthy.
The QEH Pulse Radio Show brought to you with the compliments of MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.